I was also gonna record this meeting, but that's fine. All right. Hopefully everyone's in. I think we have one person that's struggling to join. We'll see if they eventually get on. All right, well, I am gonna just start off. I have some intro slides for everyone today. First off, just to say hi and welcome you to pre-health shadowing. And then we'll go ahead and let Dr. Psych and Alexa go for their presentation or their speaking points, and we can kind of learn more about the pathways to psychiatry or to being a psychiatric nurse practitioner, which I'm very excited about. So first off, hopefully you guys can see all of my slides. From my point of view, it says you can. So I just want to say hi and welcome to everyone. I'm going to be starting a quick startup presentation, tell you guys a little bit about us. We are an international student-led, minority-led nonprofit for medical advancement. We run solely off of volunteers, and we have a plethora of different roles, and I'll be going over those shortly. Just so that everyone knows, we do mute ourselves upon joining. If at the end you do want to unmute yourself and talk, you're more than welcome to. You can just raise your hand and wait for us to call on you so that we don't have a lot of mic interference there. We do have closed captioning to accommodate students' needs and their abilities. And if you have any ideas on how we can be more accessible, we're always looking for more. I know that Zoom isn't always perfect, and sometimes the translation gets a little bit wonky. I do try to make myself very clear when I say stuff so that the transcript can be as clear as possible. If you have any questions about that, or if you really can't understand what's going on, you can always email us at info@prehealthshadowing.com, and we can send you notes or a transcript or anything that can help you out in that regard. Don't forget to save us as a contact, though. We do frequently go to people's spam sometimes. And if you join our email list, then we can also send you information about other sessions as well. So if you want to stay in the loop, that's a great way is our email list. You can join that on our website if you just scroll to the bottom and go to where it says that email list. And if not, we're also on Instagram, we're on TikTok, we're on YouTube, and we're on Twitter, and LinkedIn and Facebook are also not on here, but we also are on those as well. So something I love to do is ask where everyone's calling from. I am in Los Angeles, California, in the USA, and I know that we have some international students. I always love seeing international students, but occasionally we get those, but most of the time it's US, Canada, and Mexico, which is also still fun, but weird to see the time zones kind of interacting. Oh. I know that our presenters are in Ohio, if I remember correctly.
We are in Cleveland, Ohio.
Even more detailed. I cannot for some reason see the chat, so I'll be moving on from that. If you're interested in being part of our pre-health shadowing, we do run solely off of volunteers. It is 100% remote, so it's perfect for everyone's schedules. You can kind of pick and choose your hours or when you're able to give time. The slight difference in that is if you want to be a volunteer, it's easy to be very flexible. If you want to be a team member and have a specific role within pre-health shadowing, that takes a bit more time and it is more of a dedication. So that's the difference. And then so volunteers this one, and then if you want to join our leadership team, that's 100% remote. I'd say that the hours differ. Sometimes they're 5-hour roles, sometimes they're 10-hour roles. It depends on what you kind of want to do within that. We do have a very different roles, and you can even at the end of this it says and more. You can even pick your own role or kind of create a role within our nonprofit. And that allows you to, I don't know, you can do multiple of these things and still get those hours in. And that would be a application. So you can go apply. There's a link at the bottom of this page. You can always just go to our website and there's a join us tab, and that tab has all of the applications if you want to just do volunteering or if you want to do the leadership. Leadership is very fun. I love all the different roles, but if you want to be a volunteer for a little while and test out different roles, you can also do that. So if you're a high school student, we do have this amazing program. It's called the High School Training Program, where we work with you to essentially start a club or an organization on your campus. This also translates to college if you're doing college, but it wouldn't be HTP. That is a separate entity. But our high school training program is one of our biggest ones. So if you are at a high school and you're looking to make a club or an organization, we do have an interest form, and you can learn more about doing that and get more education on how would that work, what would you do, all of those questions get answered there. If you do have any other questions, you can also email us at info@prehealthshadowing, and that will help you as well. So something that we've been wanting to start, I'm also interested in doing an MCAT panel, but we have these diversity panels occasionally that speak to different disparities such as racial or LGBTQI plus, sexism in education. There's a bunch of different topics that we love to speak to that are diversity based, and I would love to start getting more panels. So if you have someone that you know is inspiring to you or that has helped you out in your journey, we would love to know them and to kind of get their information. So if you would love to do that, that is amazing. And you're more than welcome to have that nomination sent over to info@prehealthshadowing. So again, we are run completely by volunteers, but our website and a lot of the things that we do still ends up costing money. So if you do have access or availability to donate, then we would love that. And you can scan the QR code. You can also go to our website. We have a little give butter in the bottom corner of our website if you want to go look at that. And we do run off of time as well. So if you want to volunteer instead, that's also an amazing donation that helps us out a lot. And if you can't, you're more than welcome to just donate your time or even just send this QR code around and say you've met an amazing nonprofit that can help pre-health shadowing. Yeah. So type your questions in the chat. I don't know if Dr. Psych wants to answer questions as they go, or if she's gonna answer questions at the end. Maybe she'll do a spread of things, but you're more than welcome to just type those in the chat. We do keep a record of them, so don't worry about them getting kind of caught in the misfire of everyone else's questions. So yeah, you're more than welcome to either jot them down or to just type them in the chat so that you don't forget them. So take good notes. We will have an assessment at the end, and then you can earn your digital certificate, and I'll have a presentation to go over how that all works. So if you can turn your cameras on, we always love seeing faces. At least I always love seeing faces. But now I will stop sharing my slides and I'll open the floor to Dr. Psych.
All right, can everybody see the agenda?
Yes.
That's yes. Hi, I'm Rachel Sieke. I'm a psychiatrist, and this is my colleague.
Yeah, I'm Lexi Dannemiller. I'm a nurse practitioner.
And so we have worked together at one point, but have been working together informally for the past year, sort of as a bi-directional mentor-mentee relationship. And so I thought it'd be very fun for us to do this as a pair, since some of you might be thinking about what pathway to go down, like what place in medicine might be a good fit for you. I know this was not the first dream that I had, and that may be true for any of you, although it was mainly the second big one.
Yeah, and for me, it's kind of a nice alternative. I had a very roundabout path into psychiatry and medicine in general. So I'm a great example of how paths are not always linear, and can get into that more today.
So I'm going to start off, maybe we can each share a little bit of our why we went into psychiatry. My why starts back in 5th grade. I actually wanted to be a clinical psychologist. And I was inspired in 5th grade by a group of teachers who sent me for training to be a peer mediator, which is a terrible idea, where you have elementary school students mediating conflicts for other elementary school students. But it made me feel sort of special and skilled as a listener, as an empathetic person, and sort of sparked an interest for that I carried through college. And about halfway through college, working on a bachelor's in psychology, I decided that as I learned more about it, that psychology may not fit exactly what my image was about that. The things that I was worried about were more autonomy, and I found that the field of psychology was becoming more and more research-based and testing-based, and I wasn't very interested in that. And after about 6 months of intense, anxious self-reflection, I decided to switch paths and apply to medical school, which meant that I had to change a whole bunch of things around. I'll get into a little bit more in the next part. But psychiatry, I think, is the best field in the world. I get to do something that's intrinsically interesting. It's interesting to learn about. It's interesting to practice. You're working with people on this very personal, vulnerable, connected level. And we really do a lot of good. Not to say that we only do good. The field of psychiatry has some things to answer to, as does the field of medicine in general. I'm going to hand it off to Lexi and sort of let her tell her why. Tell us her why.
Yeah, so I've always been interested in psychology as well. Never really thought about psychiatry. I always looked at it more from a lens of sports psychology. First in my, original career, which was a professional athlete, which then turned into, I think I wanted, go into a more, kind of a more in-depth look at this psychology, which brought me into the medical field. And yeah, as soon as I started working in it, it felt aligned. I think psychiatry looks at the shadows of what culture doesn't really like to look at, and what, we talk about in our social world. So you get to learn more about people in a very in-depth, complex way, and use our minds and use our minds. Yeah.
Always. Always. I feel like I'm always learning my job. And Lexi can attest to this. I say this all the time, but psychiatry is an open book test. That the actual practice of medicine really, it is very knowledge heavy, and you do have to, sort of have a large pool of knowledge to draw from. But you don't have to know all of the answers. You don't have to remember all of the dosing. You don't have to remember exactly every protocol. We have Google and PubMed. And it's perfectly good to have sort of a core of knowledge that helps you to identify things and understand what information you need to get to. And you don't have to know it all the time. If anybody has any questions at any time, please feel free to chime in. If you want to use the hand raise emoji, that would be fine, or just unmute and start talking. I like things to be pretty informal, and I use an agenda and not a PowerPoint because I find it very cognitively taxing to make and use PowerPoints. Do you want to do your story first, sort of in like the path that you took?
Yeah, so I touched on this briefly already, but more specifically, I got my undergrad in psychology, and directly after that, I went into professional sports. So I went overseas and I played volleyball for a few years. But during that time, I knew that this wasn't going to be my path for the rest of my life. So I continued on with school. For some reason, I was drawn to the healthcare field. I think because of some volunteer work that I did in college, I just knew that a hospital setting and working with people directly was what I wanted to do. So I continued with nursing while I was playing, and actually had a dream of becoming a nurse anesthetist, so a CRNA. So that drew me into my first job as a nurse, which was in the ICU. I found out I was not an ICU nurse at all. ICU nurses have to be very authoritative, fast thinking, and I really wanted to talk to people more. A lot of people will say they like their patients sedated and intubated, but that's the opposite of me. I like talking with people and learning about them. So I often was given patients who had psychiatric illness on top of whatever medical illness they had. And I was like, why am I doing this? I should just go into psychiatry. So I did. I made the leap over. I changed my job. I started school as a psych nurse practitioner, and now I'm a nurse practitioner. I just started 6 months ago seeing patients, so it's very fresh, which is why I'm grateful to have Dr. Psych over here to be my mentor and guide me through this with her experience. But really, it's been an excellent, fulfilling career path, and I wouldn't have chosen anything else at this point.
I have a quick question. Why'd you go the NP route and not the MD route?
I think at that point I had already had my undergrad in psychology, and I started working as a nurse. You're saying like why I went back as a nurse?
Mhm.
Because I wanted to become a nurse anesthetist. And so the pathway for that was just to go straight into nursing. I don't think I ever fully considered the going the medical route, but I'm glad I did. I have a lot less debt.
True
And I get to
story.
do the exact same thing. So it was just a more direct pathway for me.
Yeah, I have a little table about the training pathways for nurse practitioners and for MDs. It's not completely uniform. But generally pretty standard. To go to medical school, you do a 4-year college program and get a bachelor's degree. You could get other degrees in between there too, but you do need at least a bachelor's degree. And then you apply to medical school, which is a 4-year program. And it can be reasonably competitive to get in, but there are a variety of things that you can do to stand out, often having interesting hobbies or an interesting personal story. Are the things that really make you stand out. Even people who have all the right numbers on their transcript sometimes don't stand out if that's all they have. But then after 4 years of medical school, you graduate, and that's the point where you are technically a medical doctor, but you can't really practice. After that, almost everyone needs to complete some sort of residency in a specialty, which could be family care, or it could be in surgery, orthopedic surgery, ENT, general surgery. All different residencies can have different lengths, which again is pretty standard across the board. There's occasionally a variation. Psychiatry is a 4-year long residency. Family practice is 3 years. Pediatrics is 3 years, but all the peds fellowships are then 3 years also. So it's kind of a bait and switch. General surgery is 5 years. Neurosurgery is 7 years. That's kind of the range. So you're spending at least 3 years in residency. And after residency, some people choose to do a fellowship, which is additional training to, subspecialize within your specialty. In psychiatry, you can do fellowships in child and adolescent psychiatry, addiction psychiatry, forensic psychiatry, consult liaison psychiatry, which is working within a medical hospital, seeing patients who are hospitalized medically for a non-psychiatric reason, but might have a psychiatric complaint. Am I missing? Oh, pain psychiatry is a thing, and sleep psychiatry. I think those are the fellowship pathways you could go through. Most of them are 1 year. Child and adolescent is 2, and I think some pain psychiatry programs are 2. I did not choose to do a fellowship. I practiced just general adult psychiatry. So I got out after 4 years, and it's actually been about 4 years since I graduated from residency. And we'll get into it a little bit later, but the actual day-to-day for nurse practitioners and psychiatrists after you get through training can look pretty similar. I'll let you go summarize the NP pathway of training.
Yeah, so nurse practitioners, we all started out with our bachelor's. A lot of nurses might just have their LPN initially and might have just gotten their associates. So usually they'll have to go back and finish their bachelor's of science in nursing. A lot of nurse practitioner programs will require that you work for a couple of years, especially in as a CRNA. So usually people will go back to school after 2 years if they're really ambitious and they knew they wanted to become a nurse practitioner pretty quickly. Otherwise, a lot of nurse practitioners have been working for 10, 15 years and then deciding to go back as a nurse practitioner. So there is a lot of variation in how much experience nurse practitioners will have before they even go into the program. But irregardless, now nurse practitioner programs are moving towards requiring doctorates for all levels. So typically now it's going to be a 3-year program. We'll have clinicals interspersed with lectures and your didactic classes throughout those 3 years. And most people are actually working during that time as well too. The clinical hours are far less than in medical school. I think in total we had about 500 to 700 hours, which is a lot less than a psychiatrist. How much?
I think it's about 10,000 hours.
10,000.
But it might be more like 12,000.
Yeah.
I saw these numbers once of the comparison.
Yeah. It's quite a drastic difference. And I think the reason being is nurse practitioner programs are banking on that nurse practitioners have worked and have gotten those hours with the day-to-day inpatient work or outpatient work, but the vast majority of nurses have the inpatient work. The scope, it does vary in states. The state of Ohio, which is where we're located right now, we have to have a collaborating psychiatrist, which means we meet with them on a weekly basis or even just once a month to talk about patient cases. But other states like Oregon, their full practice authority, I think, I want to say majority of states are full practice, or it's around 50-50 at this point. And then there's even more restricted practice down in Texas and maybe some more southern states. And yeah, that's the scope as a nurse practitioner. If anybody has any questions about that, please feel free to ask.
Yeah, and I want to emphasize how confusing it is to navigate this. Even as somebody who's like gone through training and is licensed to practice, sometimes it still is confusing to figure out all of the state by state rules. And if you decide to move for whatever reasons that you need to go to a different state, there are some subtle differences both in the medical laws and the practicing laws, licensing laws. It is hard to keep track of and sometimes changing, especially with the pandemic. Telehealth prescribing rules are in a state of limbo the past 3 years. So it does get very confusing.
I had a quick question.
Please.
I know for a fact that MD PhDs have been getting bigger. Did you ever think about that route yourself? And do you have any knowledge on, the time for those or kind of what that pathway would look like?
I know something about it. I never thought about that for myself because that sounds terrible. Because personal preference only, though, just to take that with a grain of salt. One of the reasons I moved away from psychology is because the research heavy aspect of it didn't appeal to me. So an MD PhD is really like you're a doctor of medicine, which is an MD, medical doctor, and PhD is doctor of philosophy, PhD, which is a little confusing. What is doctor of philosophy? It's not a philosophy program, but usually non-medical doctorates broadly are often PhD. There's also a PsyD that you can do for clinical psychology. That's doctorate of psychology that has a slightly different path and I think is more clinically oriented. Usually MD PhD programs take 7 to 8 years, I think, like instead of the 4 years for medical school. It varies a bit because the PhD part is more flexible about how long that will take you. I think because you need to complete a clinical research project and a dissertation. And some people might do that faster, and some people that might do that in a shorter timeline. You might be, there were some MD PhDs at my medical school who were, I think, with us for the first 2 years, but then when we moved into third and fourth years of clinical training, where we do like clinical rotations, they moved on to do research years. So they were sort of off sync then with the people that they started with. And not necessarily a bad thing, but maybe something, a challenge to be navigated. And then I think 7 to 8 years is pretty typical. It is an advantage if you want to work in academic medicine and publish, although there's not really any barriers I'm aware of that you couldn't do with an MD that you could do with an MD PhD. It just might make you more prepared and give you the sort of paperwork credibility that is such a valuable currency these days, or a valued currency. I'm not sure if valuable is the right way to put that. But good question.
Before you ladies continue, Anna had a question. She wanted to know, how does the daily life of a nurse practitioner look like in psychiatry?
Yeah, so that's actually where we're leading to next anyways. My role in psychiatry, I'm an outpatient geriatric psychiatric specialty. So I see patients every day in the office or telehealth. I have an odd schedule. I start really early and end really early. So I'll start at 7 a.m. and I'll end at 3:30. And I'll have 30-minute appointment slots for patients that I've already met before and had intakes with. And then I'll have 1 hour, slightly over an hour for new grad. To have
new evals.
For new evals, to meet people, really get their history, spend a lot of time with them. You're usually documenting during the visit, or now with AI technology, if patients agree that they want to use that, that will actually help us do the notes. And of course, we have to look over it afterwards before we sign it, but it really eases the documentation piece so we can really get to know our patients. We talk about what's stressing them, what their primary goal is, and what we can do to help them. A lot of it is medication management, but something that both Dr. Sieke and I work on is looking at the whole person. So we're looking at lifestyle interventions, cognitive beliefs that are more psychologically rooted, and then also medication management. So there's a lot to do within that hour or that half hour, but we do it.
Yeah, some of us run a little over. My day looks surprisingly similar. So where I work right now, I have a solo private practice. So I work for myself, and I have a much more variable schedule, and I start late and usually end late because I'm a night owl. But usually I'm seeing patients for an appointment slot, documenting, sending in medication if needed. I do a lot of psychotherapy with my patients. So I mostly see people for hour-long slots, or occasionally even longer than that. When I see new patients, I usually see them for 90 minutes to get kind of deep into things. It can be hard to gather all of this information about somebody's psychological health, which isn't only an illness history, but also a social history, and looking at some of their traits. How do they typically deal with conflict, stress, resilience factors? So you want to understand like that whole person, and that often takes quite a while, even beyond an initial evaluation. Sometimes I'm just barely scratching the surface. I might have a working diagnosis or hypothesis, and that might change. A lot of times I'm not as attached to putting somebody in a diagnostic box, but trying to understand them and what are the things that are interfering with your daily functioning that are creating distress, and trying to figure out with them, like, how do we mediate those? How do we manage those factors and lean in on your strengths, support the weaknesses, and get you to sort of the whole body care, which is exercise, nutrition, social connection, which is maybe the biggest factor, exposure to sunlight, and a sense of meaning and fulfillment. In terms of our types of patients, that could be entirely the same between us. Lexi specializes in geriatrics, so older patients. I see general adult patients, so people from 18 up. Sometimes people who are in the geriatrics, which is technically over 65, but some people are very young, 65, some people are very old, 55. Very so much. So that's sort of our patient population. I enjoy treating people with anxiety disorders, a lot of health anxiety, see a lot of patients with medical trauma and like chronic medical illness that is related to the psychiatric illness. Also have some niches in dissociative disorders and catatonia.
Yeah, and like Rachel said, I specialize in geriatrics, so I do have maybe 20 to 25% are struggling with cognitive impairment or dementia. The rest are, severe mental illness. We see some, depression with psychosis and bipolar and schizophrenia, and also just some anxiety. I truly have an interest in PTSD. I think it's really hard to get people to trust you when they have a severe trauma. And so establishing that relationship is really important to me. I enjoy doing those kinds of, that kind of work. And yeah, that's all I have to say about that.
Yeah. I wanted to share, if people are interested, a little bit about my own personal journey that's sort of paralleled throughout my training journey. When I was in medical school, I had a number of health issues that came up. That was really the first time I dealt with any sort of serious health issues, in being in my early 20s. And that was actually a really important developmental process for me that I look back at as almost being an advantage. And it was a stressful time, but it gave me a look at the patient side, and not just the patient side of you have a sinus infection and you go and you get an antibiotic, but of the complex way that you have to navigate the healthcare system when you have something going on with your health that is not clear, that often you might need to see multiple people having different perspectives, sometimes not really believing what you're saying, sometimes believing it and not having the answers, or telling you an answer that doesn't make sense to you. So I had some really good experiences as a patient and some not so good experiences. And looking back, I'm really grateful to have had that experience so early on. This was like at the end of my first year of medical school. Terrible time for developing health anxiety, which there's a medical studentitis, which is like very legitimate and real. But it really was before I developed an identity as a clinician. And as I went through training, it kind of was something that helped me keep that experience in focus as I developed, and maybe resist some of the biases that we see in medicine towards efficiency and putting things into boxes, and not always connecting and understanding somebody's experience and being able to hold the depth of it. I see a question in the chat.
Yeah. Aja said, what do you think makes the patient-provider connection in psychiatry unique compared to other fields of medicine?
Do you mind if I take this one?
Go for it.
It is unique. It is closer to a therapy relationship than and well, really in other areas of medicine, there is a physician-patient relationship, but there's not really a therapist-patient relationship. And we develop both of those. Even providers who are really only doing medication management, there's a different set of ethical rules that we have to follow that is separate and in addition to the ethical rules for the rest of medicine. Honestly, there's the rules, ethical rules for therapists and the ethical rules for doctors, and we kind of have to follow both of them, which is perfectly justified. It is particularly vulnerable to ask for help for your mental health. Partly, maybe even largely because of the stigma we have in society, how we feel about that and how we construct that makes it very difficult to admit to and seek help for a problem that is occurring in your emotions, your thoughts, your feelings, behavior. People have trouble understanding how that develops from the biology into the manifestations, which can look like personality, character, intention. But start off with biology and genetics, just like any other aspect of medicine. So I think the polarized aspect of it makes that connection harder for some people to reach out for and establish, but also once you make it, it can be stronger and more intense in a lot of ways. Anything that is difficult is also something that we hold more dearly. And a lot of times, I think good psychiatrists and psychiatric providers are thrust into a bit of a role of advocate for their patients, to try to advocate to the rest of the healthcare system that whatever is going on psychiatrically does not mean that they can't have a medical problem. A lot of times people who have a history of psychiatric diagnosis, it can be an easy way to explain vague or difficult to understand symptoms that are happening medically. And so one thing you have to remember is just because something isn't clearly falling into a medical diagnosis does not mean it's a psychiatric illness. It still has to have the characteristics of a psychiatric illness. And so we need to remind our colleagues in other specialties that people with mental illness experience medical health issues, not just at the same rate as everybody else, but at higher rates than everybody else. So please don't, dismiss what they're coming to, even if it might be difficult to understand, and it might be filtered in the way the patient tells it to you through the lens of a mental illness, which might distort that, and you have to unfilter it.
And then Leslie Gonzalez talked about how you're keeping your work and your personal life different, and said, how do you leave work stuff at work and go home, especially coming back from a stressed out case or day?
I think we should both answer this one.
Yeah, this is incredibly important. As providers and as doctors, especially through residency and training, you're not necessarily taught a good work-life balance. You're thrown into 80-hour work weeks. So it's really hard, I think, as psychiatrists and as nurse practitioners to be able to establish that work-life balance when it's not really established for you in the beginning. So for me personally, I just really have to have good boundaries around that, right? Like, being available and being there fully 100% when you're with the patient and when you're in your hours, but then having the time to yourself outside of work, maintaining those boundaries. But in addition to that, having close relationships with other providers where you can be vulnerable, where you can talk about your feelings and everything that's going on. If there are any transference feelings or even codependent feelings that are starting to develop, you have to feel vulnerable enough to talk about it with another person. And so that's something that collaboration time can be good for, or having a mentor, or establishing relationships with your colleagues. But we are social beings, and providers are not immune to that, and providers themselves are not immune to depression, anxiety, trauma, and any of the illnesses that we treat. So we have to be able to rely on each other and establish that sense of community.
Well, I would agree with that. I think the biggest way to protect yourself from things like burnout, I see a question sort of down here about feeling burnout in your line of work. I absolutely have felt that. And it's sort of the reason why I left my previous job at an academic hospital to go into private practice, is not just burnout, but a variety of things that I would also call moral injury and workplace bullying. And those are part of my story. And workplaces can be sort of complicated. I'm happy to talk more about those, any of those things if people are interested. But the field of psychiatry, I see this about emotionally heavy. I often get this question when I talk with students, and I think it's not emotionally heavy in the way that you're asking the question, like the emotional heaviness that a lot of people, before you go into it, see is the heaviness of holding people's stories and crisis and distress. And it must be hard to be a container for that. And I think a lot of that varies individually. I do not find that to be difficult. Usually, as people are telling me those things, I'm sort of seeing the strategy for how do we get them to feeling better, and feels like in a place of sort of hope and almost like solving a puzzle. And so I don't usually feel drained or burned out from whatever the patient is bringing to me. What has often burnt me out is the system problems that have created unequal access, that create financial, transportation barriers, bias from other providers or agencies, paperwork and logistical barriers that people just can't navigate, and the push-pull of like, how much of my own personal resources do I try to invest in helping somebody navigate the system when there really aren't adequate resources to help them navigate a confusing system that I only sometimes understand. And sometimes the complex issues of treating people with mental illness, which sometimes includes a loss of insight about being ill. And when that happens, sometimes people lose the ability to make decisions on their own because they are not able to see the important factor that they're suffering a serious life-impairing illness, which is pretty necessary to be able to make a competent medical decision. So sometimes we're in a position of having to make decisions against somebody's will, to involuntarily hospitalize them or restrain them or chemically restrain them with sedating medication. And those things can be traumatizing, even if they are necessary. And those things sometimes create moral injury, which sort of adds to and is related to burnout. Thank you, Litzy and Leslie, for asking those questions. I'd like to open it up to just free form question and answer. If people want to just say it rather than writing it, or if you prefer writing it. I am a person who strongly prefers verbal communication. Reading the questions is fine, but I would always rather say my question than write it. So welcome everybody to do whatever feels most natural to you. If coming, like putting your camera on feels natural, do that. If it doesn't, don't do it.
I would love to hear you expand a little bit more on Litsy's question and say, like, how do you deal with burnout? Like, are you more hobby focused? Do you, I don't know, go to the beach, play with your kids, have pets? Like the personal side of things.
So I have pets, and a lot of the way that I manage burnout is by connecting with peers. I've really had a lot of success managing that by talking about my experience of burnout with other people and processing it. I also have a therapist, and have a few times seen physician coaches, which I found pretty helpful. Uh, I don't think there's a one size fits all answer. I don't also know that I always do this in the best way.
Yeah, for me, I do all the hobbies. I started this zine group to kind of emotionally let go of things, which is essentially like adult art therapy, but we just kind of create collaborative zines together, expressing everything that's going on in the world. And exercise is a major part of my day, and getting out on walks and enjoying the weather when in Cleveland is only about 3 months of the year. But yeah, those are some small things I do to take care of myself. But yeah, very important to be able to fill or to pour from a full cup.
I wanted to know, so how do you guys like determine if someone needs like psychotherapy or if they should be put on medication?
What a good question. Um, uh, some of that's very individual, and I do a lot of both. Usually, my patients are on some sort of medication, and we're also doing therapy. I would say I have a handful of patients who have meds only, and a handful of patients who have no meds and we do therapy only. But a lot of times, if people are only looking for therapy or only need therapy, they can see a therapist who's not a psychiatrist, because therapy is also the realm of a number of other licensed professionals, whereas the intersection of therapy and medicine is really ours. So a lot of the therapy that I do is kind of meant to be delivered in my role as both a medical doctor and a therapist. It's about understanding the complex interplay of your biology and the way that the nature and the nurture, and how that's being perpetuated, and just sort of helping you to understand the why of your feelings and thoughts and behavior. But it's not something that only I decide. It is absolutely a shared decision that we make with our patients, and it always should be. That a lot of it has to do with the personal preference of the person who's seeing us. And there's not totally a right or wrong answer. I think if therapy alone is going to be adequate, that has fewer risks, not none, but perhaps fewer and less tangible risks. Not everything really does respond to that, though. A lot of times, just sort of because of the way the system works, by the time people have come to see a psychiatrist, if they were interested in therapy alone, they may have explored that already before sort of coming to the step of seeing a psychiatrist. Or they might be so ill that they're cutting through that process, or they may not be interested in therapy. So there's a little bit of a selection bias in the people who might come into our clinics, that they, either are more seriously ill and in need of medication, or have a preference that is more for sort of like medical, tangible treatment and not the abstract, indefinite work of therapy. Some people strongly prefer the sort of the work of therapy, which also has sort of like a more infinite potential than like the tangible medication, which works or doesn't work. And then I have to deal with the hope disappointment cycle.
Yeah, I would just add to that psychiatry is one field of medicine that is not an exact science. It is an art. And so there has to be buy-in from everybody involved, including family, if family is heavily involved. But we have to kind of make that decision. I would say most of the people that come to us, like you said, with the selection bias, already are on medication or are interested in medication. So generally that is, a large part of the conversation. But if not interested in medication, then okay, let's look at what can we look at in your life to avoid medications and maximize your quality of life without having to go down that route, but maybe not be so against it that it's not an option.
Also, the evidence does suggest that exercise is probably as effective as most of our medications, at least for things like anxiety and depression. It gets more complicated with when you get to some other diagnoses like bipolar disorder, schizophrenia. That certainly is a bit more complicated, and probably medication is going to play a bigger role. But the really lifestyle and therapy interventions are not ineffective. It's not exactly like they only treat mild cases. But what I often find is that the symptoms of the illness with mental illness make it difficult to actually engage in those lifestyle and therapy type interventions. And it like just sort of raises the bar, the threshold of being able to do that work. Most mental illness on sort of a biological level decreases cognitive flexibility. And so people are less able to stretch themselves, to grow, learn, and tolerate. So they may just really not be able to get themselves moving into a place where they're able to do those things, even if they know that they should do them. A lot of times the guilt and shame process of, like, I know I should do these things, and I'm not doing them, compounds the illness. And so sometimes medication is really the springboard that gets you into a place of more neuroplasticity, where you're able to be more cognitively flexible, where distress is easier to tolerate and move past. And then you're starting to be able to do the things in your life that really do build and maintain wellness. And I think that's a very legitimate way to use medication, and I'm happy to do it. Who else? Does anybody else want to ask maybe some specific questions about their journey? Anyone want to share where they are in schooling or training?
I'm happy to share. Maybe it'll get the ball rolling. I am trying to get into psychiatry. I'm working on all my med school applications, primarily secondaries. Those are a beast. I thought it'd be easy because I was going, there's only like 2 or 3 questions, but a lot of them are very personal. So if anyone else is submitting their applications, definitely don't take it for granted. And I'm still in the MD, DO, which one's best for me, route of things. So I always ask in every session, MDs specifically and DOs, not so much PhDs. Sometimes PhDs will surprise you and they'll know the difference between MDs and DOs. But did you think that or consider DO ever?
Yes. So actually, there's a pretty large concentration of DOs in Ohio. Actually, I think that's where so DO is doctor of osteopathy and MD is doctor of medicine. There's really no difference in like the day-to-day practice. Like once you go through training, there really are no sort of restrictions on like you can do this with an MD and you can't do this with a DO or vice versa. The DO training does involve a more like holistic component, and that's like part of their core philosophy. And they learn, I always forget what the acronym is. And there's like a sort of physical technique that you learn in osteopathic training that is about sort of manipulation of the body that we don't learn in medical in like an MD program. But even though, like I'm saying this, like these are the things that DO has in addition to MD, and there really isn't anything they don't have that MD does have. It still is considered to be a little bit less prestigious and less competitive, and those programs generally are easier to get into. And so there's sort of like a thought that it's a lower quality pool of applicants. I think that exists more in the training realms than it really exists after that, when people are practicing as full, physicians after residency. Honestly, some of the best physicians I know are DOs. And one of my really close friends is a DO and pretty involved with like the DO board. So I have nothing but respect for it. I think there's a little bit of an underdog path that you go through. You might be easier to get in, but harder to prove yourself as you go through. They have different, like, board exams. They have a different set. And if you want to apply to MD residencies, there's like some residencies that are specific for osteopathic students. If you want to apply to the whole full spectrum, you'll have to take our board exams too. But you can't avoid taking yours, which are the COMLEX, and ours are the STEP exams, step 1, 2, and 3. I think it's COMLEX 1 and 2. I'm not sure if the third one might be step 3 for both. But when I was working at my last job for 3 years, I had medical students with me, like pretty much full time, and they were all coming from a local osteopathic school. And I was very impressed with the quality of those students.
Yeah, Ohio's very well known for their psychiatry program for DO.
Yeah, I was like the 3rd year clerkship preceptor for Ohio University, and I would recommend it. I think the students got really good training.
Stemming on that, I do have had like conversations with other doctors who are saying that they think med schools should start incorporating more patient care or bedside manner stuff into their coursework. Do you have any advice for other people with patient care or bedside manner that you think that you should highlight that maybe other people
A lot
don't?
of the quality of your learning does happen in your 3rd and 4th years, when typically 1st and 2nd years of medical school are sort of like classwork, where you're learning normal anatomy and physiology and pathology, and then in 2nd year you learn like pathology, meaning the abnormal. Like we're learning how it works when it's working well, and then we learn how it works when it's not working well. That sometimes in a different order, different programs will do that differently, but generally the first 2 years are sort of classroom based and might look more like college looked. And then 3rd and 4th years are clinical rotations, where you have very little, if any, classwork. You might have like an hour to a week where you join, in these days probably virtually. And most of your day is going into the hospital, working with a physician or a team in a hospital or an outpatient setting, and sort of shadowing. You might be involved to more or less degree, depending on the specific work that's being done. Like if you're scrubbed into surgery, that you'll do a lot of retracting. You're sort of pulling things back so that people can see. And they'll let you do a few token things, but you're not going to do the heavy lifting. What I would have my students do, a lot of times they would be shadowing me and watching me interact with patients. But for almost all my new patients, at least, if they agreed, but most of them did, I'd have them interview the patient first and take a full history and come back and present that to me, along with sort of their thoughts about, what the assessment might be, the diagnosis or treatment plan. And then I would re-interview them and sort of do that again. And I would do that with some of my follow-up patients too, whoever I sort of judged to be a good learning case, and also, again, who agreed. And that's how people might be involved in an outpatient clinic, is often you'll go in and take a history and sort of get familiar with that. But at other times be observing the doctor that you're working with. The quality of that just really depends on the individual clinicians that you're working with, and also like the organizations that your school is linked with. Like, what is the culture there? I mean, there's individual differences in clinicians, but also a very toxic organization that emphasizes, profit and throughput, or, see patients and get money. It's going to burn a lot of people out, and a burned out clinician is not really going to be as good of a teacher.
Another suggestion that I might have, if you are in your undergrad program, or you have and you're working while you're studying, working as an aide or something other than just studying and being in the healthcare field and working on the bedside actually helps you develop that bedside manner. I think that's why people, some people will prefer going to nurse practitioners, especially in psychiatry, because psychiatrists can be scary, if they don't have that bedside manner. And you're thinking they might just be judging you and you might not feel vulnerable. But working in the field and being at the bedside with patients one-on-one really helps you develop those skills. So I think, yeah, that could be a suggestion too.
Yeah, I volunteer at my local hospital. I love it. Always recommend people do that. It's definitely a different experience. So my thought.
Practice with the interactions and like observational education with good quality clinicians. One of the things that I will tell you as advice is that you will make mistakes. You're going to say the wrong thing, and it's going to be stupid, and it's going to feel awkward. And as a student trainee, really, you should have a limited ability to really fuck things up too badly, because everything that you do should be done by a licensed professional, and really essentially for practice. That being said, that it varies to a degree, but get prepared to make some mistakes and do not feel bad about it. I really, as a teacher, emphasize to people that we need to normalize making mistakes and causing harm in medicine, in life. I think that it generalizes for me in a bunch of other aspects, but specifically in healthcare, we are in a place of authority. And when you're in a place of authority, you can help a lot of people, but you'll also harm other people. Some of it is like a gamble. You roll the dice and you get what you get. Might be a solidly founded plan on good evidence that was thoughtful, and somebody has some weird adverse effect that was a risk but a low one. If you practice enough, you'll see all of the unusual side effects and other ones that nobody has documented and you don't really understand. And sometimes you've missed part of what's going on, and the plan that you made sense for what you were seeing, and doesn't make sense actually for what's really going on. I say it all the time. The most common reason for treatment resistance is incorrect diagnosis. And so I think that we do need to normalize the fact that we will cause harm. It is not something that can be avoided. And there is sometimes an attitude of like high stakes, that we're in this position of authority and we can't hurt anybody. You do. You will. The best physicians will. You can be upfront, transparent, and humble about it. And that really is worthwhile. Humans really harm other humans, always. Looking in the chat, I see
We have a few.
Yeah.
So I'm going to start with Mathad. He did say, in your training, was there anything particularly difficult or emotionally, or that's emotionally or mentally difficult?
If you don't mind if I jump off, what was really difficult in my medical school training was like dealing with some health issues. I was hospitalized for a little while, and there was a mystery aspect of not clearly understanding what was causing my symptoms, which created a lot of distress. When I look back on that, I really do see that as one of the most important experiences that I've had that I wouldn't trade away. But that's how I look at it now, more than a decade later. At the time, and for a couple of years, it was an ongoing stress and something that was pretty difficult to navigate. And I would say, actually, the other very difficult thing was actually after I graduated and had my first job, I experienced just a different culture and environment that the bubble of training sometimes can be pretty toxic and sometimes has a different set of protections than for physicians and healthcare providers after they graduate. And I had a lot of privilege on the training side of it that I did not understand I wouldn't have on the other side of it. And I did feel like my identity as a woman and my identity as a person with a disability, which is something I've more recently claimed, put me at odds with the system of healthcare and healthcare administration. And so those things were pretty difficult, and things that I am still navigating. A lot of positive things that I've learned that have helped me grow in a lot of ways, but also harm and drama. I'd be happy to answer other more specific questions if anybody has them. Really, I'm an open book, and I'd like to share and have Lexi share her experience too.
We-
Go ahead.
We can
will-
bounce back in the chat. You wanna go back and forth, Kira?
Yeah, it's fine. You go.
Yeah,
Go
cool.
for it.
So we had Mr. Costa basically say that she's a high school student, 12th grade, and she's really passionate about pursuing an accelerated path to medicine and becoming an OBGYN. She says in her country, they have a program called Leap Med that allows early entry into medical school, and they recommend learning medical concepts like physiology and anatomy beforehand. She wanted to know, do you have any tips or advice for preparing for the entrance exam, especially studying these concepts?
I imagine that there's a bunch of things. I'm trying to remember like the things. I don't know that people even use the same resources that I would have used back then. Like I learned some of those things in college and some in medical school.
Oh, I have a good Picmonic was my favorite.
It's the thing I was trying to remember, that was really popular when I was in medical school, and I think still is a thing. It wasn't exactly, I didn't actually prefer it because it's just not my like learning style as much. I'm more of a kinesthetic learner where I learn by doing. I especially learn by teaching. But like reading is a good way for me to learn, or talking. But the visual aspect of that just didn't exactly gel with my learning style. But a lot of people really liked it. See if I can pop a link in here.
I also learn best through teaching. I always tell people I have a symbiotic relationship with them. They're learning and I'm learning.
I say that too. I do a lot of teaching and mentoring because it really benefits me just as much.
If you're ready to move on, are you still answering this question?
I just got a link.
I also recommend, if people like pictures and they're studying for the MCAT, Sketchy. They have free videos on YouTube, but they also have a subscription.
Yeah.
So Ahana Rustagi, hopefully I said that right. It says, hi, I'm a rising senior currently, and I am hoping to study for the pre-med path. I am soon going to start volunteering and shadowing at a local hospital and was wondering if you had any advice for me. What can I expect, prepare for, etc.?
Oh, I did that too. I volunteered at a local hospital. And I remember doing a fair amount of restocking of things, which was intensely boring. And then also going around to patient rooms and asking them if they needed anything, and getting people water or pudding, which that was fun. And sometimes just sitting and talking with people and having, random conversations. Really, a lot of what people need in a hospital setting is companionship and distraction. And even without a license, you can offer that, and it's really valuable. So I would encourage you to lean in as much as you can to that aspect of it. Ask people questions. And don't be afraid of asking too much, of being intrusive and invasive. I think as a society, there's way too much messaging about that limits our curiosity. And we're so afraid of violating a social norm that we tend to ignore and dismiss people's concerns when we might in fact be curious. But I would say risk insulting somebody or offending them rather than risk missing them and not seeing them.
Yeah, I love that. I think that's like a great analogy. We had another question from Anna. She says, how does the process of sending someone to a mental hospital institution work? I am a pre-med rising senior and am currently doing summer research on institutionalization and its history in CT.
Yeah, that's a good question. Institutionalization has definitely evolved since the beginning of mental health care. We used to be sending patients to hospitals for a long period of time, and that carried its own stigma and abuse within the system that was really harmful. Nowadays, we've evolved into more temporary stays. So if someone is critically ill and they are at risk of harming themselves, risk of harming others, if they're catatonic or just really cannot function on their own, we will likely encourage them to go themselves and volunteer to go. But if, you know, if they don't want to, it's against their will or something, then we have a system called a pink slip where we would have to send them to the hospital against their will.
Well, that's actually what we call it here in Ohio, but that language is not common across the US.
Didn't know that.
And the rules about involuntary hospitalization are state dependent, which makes things very confusing. The way it is in Ohio is there are 4 criteria you can use on as a basis for involuntary hospitalization: risk of harm to self, risk of harm to others, inability to care for self, or so gravely disabled that it is sort of risking violating your rights or the rights of others, which is a bit of a catch-all one. Those 4 criteria are pretty standard across the US. There might be some like variation in wording, but essentially the concept of harm to self or others, or so ill that they're unable to care for themselves, are the standards of being able to override somebody's wishes to involuntarily hospitalize them and sort of take away their liberty. It is usually a sort of prescriber level provider who can make those decisions. Again, that varies a little bit by state. In Ohio, all physicians could pink slip somebody. That's what we call it here. It's like 5150 in California. I can't remember they called in Michigan. I had somebody
3-day hold.
Yeah, we sometimes call it that. Here it's if you pink slip somebody, they are admitted then for a 72-hour psychiatric hold. And 72 hours does not mean 72 hours. It means 3 business days. And if you would happen to go in on a 3-day weekend, those 3 days of the weekend would not count towards it. And you cannot leave voluntarily. Like, you're in there until the end of those 3 business days, at which time either the physician, the psychiatrist on the unit could discharge you, or if they believe that you're still at serious risk to yourself or others, or unable to care for yourself, they can apply through the courts for a probate hold. This is like through part of the civil court system. It's not a criminal thing. And then you can do either a 30 or a 90-day hold. we don't have to keep people the entirety of that duration. And even with this 72-hour hold, the physician or the psychiatrist or the psychiatric nurse practitioner in the unit could decide to discharge you earlier, but don't have to. And usually nobody gets discharged on weekends. It's just a reality. If you sign in voluntarily, actually you can't sign out voluntarily. And that's something that I think a lot of people don't understand. And I make sure that I'm telling patients if we're considering going to the hospital, because that can be really jarring and appalling if you go in there and feel like this, betrayed that, well, I came in voluntarily, that I thought, I'd have, if it's not good, I can check myself out. And that isn't the case. Signing voluntary sort of gives an indefinite period of time of treatment. And that ends when the treating provider decides that you're ready for discharge. If you decide you want to leave, you can write what's called a 3-day letter, which then converts your stay to an involuntary one. And now you get those 3 business days starting from that point. And it doesn't count any of the time you were there up until then. Does that answer your question?
Yes, thank you so much.
You're welcome.
We had another question from Litzy again, saying that they are currently a 5th-year undergraduate student in Colorado and considering applying to a graduate school for PA studies, and was wondering if you worked with physician assistants, or if you worked closely with them, or if you've even typically collaborated with them.
Actually, I don't know exactly why this is. It's less common to see physician's assistants in psychiatry and much more common to have nurse practitioners. In some other fields, it's like in surgical fields, I think the opposite might be true, where physician's assistants are pretty common. I haven't actually worked with any physician assistants that, just by chance, and I've worked with a lot of nurse practitioners. When the collaboration is maybe not as much as it should be, because we work in a parallel way, and not so much in a dyad way. In some fields, like say in family practice, a lot of times you have like your primary care doctor who might be an MD or DO, and if you have like an acute issue, you develop a sinus infection or have a UTI, you want to be seen, right away within a day or two, and you call the office, or if they have some sort of online scheduling thing, you get put with somebody at the practice. And a lot of times that's a nurse practitioner working in collaboration with that provider. And they'll see you sort of for the acute issue. And usually they aren't necessarily seeking supervision from that provider in the moment, but do meet regularly with that provider and could ask them if there was something that come up that they didn't know. And so it's sort of like there's a like sharing of patients and responsibilities, where the physician kind of has a more supervisory role, and is often seeing most of the patients, and there's like sort of an overall assessment from them. And then, more acute or intermittent follow-up care is managed by a nurse practitioner or physician's assistant. In psychiatry, for whatever reason, that's not really, well, not for whatever reason, I understand some of the reasons, but that's not really how it's practiced. It's generally, I have a panel of patients who are my patients, and Lexi has a panel of patients who are her patients. When they need follow-up, she's the one who follows up with them. And when my patients need follow-up, they follow up with me. At my last job, I had 3 nurse practitioners that I was the physician collaborator or supervisor. In Ohio, it is partly restricted in that all nurse practitioners have to practice under a physician's license. And there aren't any specific guidelines about what supervision is. Like, I would meet with people weekly, but you could meet with people monthly or be available to them as things come up, there isn't like a complete standard about how you have to deliver supervision, but there's like a connected with your license and then a supervision aspect. But for the most part, they had their patients and I had my patients. And occasionally, like they sent somebody to me for a second opinion, or I would transition a patient of mine to one of the nurse practitioners I worked with, but that's not the norm, really. So usually it's you might collaborate in that you would discuss cases, but not collaborate so much in that you are sharing in the care. So maybe a little bit different in the inpatient setting, where a lot of times the nurse practitioner will have to meet, sort of discuss the care of the patients on a daily basis with the inpatient provider. Again, that varies some. And it could be kind of cursory, but still usually they're carrying a panel of patients that they're sort of responsible for, and then the physician would have their own separate panel.
Okay, thank you for that. We had another question from Pratham. I apologize if I'm saying your name wrong. And this is actually a question I have for myself as well. It says, planning on joining a research lab, do you have any tips on ways to increase my chance in joining one?
That's a good question. I would say cast a large net and try to be visible. Like I hated that process. It's just like the not just the research part of it, like writing a research paper gives me a terrible amount of anxiety. There's like, give me a screaming patient any day. I would much rather deal with that. But that's, some people feel completely the opposite. But the politics of it, of sort of like asking people, like, do you have any research and can I join you? That I thought was very anxiety provoking. So I would say, like, acknowledge that like, most people do find this to be pretty anxiety provoking, to reach out to these people of authority that you barely know or don't know at all. Sort of like in a psychology standpoint, things that make you stand out are, might be an unusual turn of phrase or some personal anecdote. Like if you are able to make your messages stand out from the usual noise. Sometimes I was in a networking thing today where they were talking a lot about signal to noise. And in our world, we have a lot of noise. We have spam email, there's all this stuff on the TV, there's all just like so much stuff that comes with that, toward us that really we ignore. And we have to pick out these signals from those. And how do we identify, like, what do we click on versus what do we scroll past? And so you have to figure out what are the elements that will make people click on me and engage with me and the message I'm sending, rather than just scroll past and ignore. I don't know that I have all of the answers to that, because I don't like doing it.
Well, if no one else has any questions, I am going to push, because we have 5 minutes left to finishing up my wrap-up slide. So any last minute questions, anyone? I don't think so. Well, thank you so much, Dr. Syke, and thank you, Lexi or Alexa. I couldn't tell which one you went by.
Either one.
Okay. For coming and for talking. I'm just going to do our quick wrap up. You guys can kind of see how we do all of that if you're interested. Hopefully everyone sees this. So we always ask for reflections, especially for people who are applying this semester. A lot of times they ask for, if you're doing any of these shadowing sessions, what was a big impact, or what did you take away from these sessions? And writing these little ones down for every session you do is a great way and a great habit to build, to make kind of a draft of that response. So our 3 questions that we usually say is, what brought you to session today? What were you excited about? What are your 3 major takeaways that you got from this presentation? I definitely loved Dr. Psych talking about mistakes and making them and normalizing them. That was probably one of my favorites, weirdly enough, because I loved everything, but that kind of stuck in my brain. And what do you want to learn more about? You can even follow up with questions on our email, or you can post them on LinkedIn. We do occasionally post those on our LinkedIn, and we can shout you out if you do end up posting those on your LinkedIn and you want to cite us. We are pre-health shadowing with the dash in it. And so you can see those on our session, and those are great ways to kind of make your network a little bigger. I know that someone asked about research. A great way is getting people who know you on LinkedIn, and you can reach out that way to professors or people who are conducting research, and you can find out what they're researching, and sometimes you can make some friends and get some networking there, so you can join their research or their lab. Again, if you're interested in being a pre-health shadowing volunteer, we are 100% remote. We work with your schedule. If you can only work at 1 in the morning, that's fine with us. We have people from all over the world volunteering. We actually have a very large volunteer base, so you can also learn more about other people's stories. So that's something that I always find enriching and very fun. If you did want to be on our leadership team, that's always there as well. Lastly, again, if you can donate, we love it. Time or money, either one works for us. You can scan the QR code. You can also just go to our website. Lastly, everyone came for this, how to get your digital certificate. You're just going to go to the same course that you got this Zoom link from. Sometimes you get that from our Instagram bio, sometimes you get it from our website, but you can go to our website and you're going to find Dr. Psych, and then the quiz is going to be up there. It is up there now. It is a 10-question quiz, multiple choice, true, false. There's a plethora of random things that it could possibly be. You just need a 70% or higher to pass that, and you get 2 attempts. For whatever reason, if it loads and there's no questions on the screen, that's definitely an error on either your computer side or our side. And if that happens, you can just email us, tell us what happened. We're more than happy to give you another attempt if you had any technical difficulties, or if you think that your answer was right and it was wrong. Happy to fix that. The one little tidbit, sometimes we have a banner at the top of our screen. You do need to exit out of that banner to finish the course so you can download your certificate. I have a lot of people that ask about that because they can't see the finish the course. There's like that weird little, I don't even know what banner it is, but you got to exit out of that and click finish the course to get the certificate. And if you missed any part of this, it will be up on Zoom. We try to have that up within 24 hours. Sometimes it's within 48 hours, but it will be up as soon as possible. If you missed anything, or your internet was spotty, or you just wanted to recap or see any more tidbits about this lecture, then you're more than likely. And we also have other sessions on there. Everything we do is recorded, so all of our sessions are up, and you can take the certificate quizzes for those as well, and you can get shadowing hours for our previous ones. It's not the same as the live sessions. I definitely love live more and interacting and questions. Dr. Psych was right. I love seeing people's faces and hearing some voices. So be sure to catch our sessions every week. And thank you so much for joining. I will be on for a bit more if you guys have any questions about pre-health shadowing or the student team or anything regarding us. And maybe Dr. Psych wants to stand around for 2 more minutes if anyone has any last minute questions, but we're good here.
I put Lexi and my contact information in the chat. Please feel free to reach out to us. We're really very normal and approachable. And we like mentoring and teaching, and we can answer more specific questions to you.
I always love that.
You know,
even if it's a
people
hello.
don't take it. I think often, like, people don't take those things up. I'm not sure that I really ever did that much. There's just like the social anxiety, inertia, but it is honestly a very good way to get different exposure and information, and can lead you to ideas that really, springboard off into really helpful things. There are a lot of pathways into medicine. I think there's probably at the stage that most of you are at, it seems like there's this one door that's, you know, grade school to college to medical school to residency to, you know, or the nursing pathway. And that has to all go like really smoothly, where you get good grades and you do all the things in the same timeline. Actually, most people get off track at some point, and you try to make that into an interesting story.
Yeah, as a non-traditional student, I definitely have my interesting story.
Yeah, I think we're all humans. I really think a lot of times the ways that we got off track are the best parts of us, the parts that really make us stand out and unique, and the the processing path of college, medical school, residency, doctor turns people into automatons. And sort of the ways that you broke from the path that may look like failures or mistakes or setbacks, those are really the things that make you you. And if you harness those, they can be advantages.
Definitely. I agree. Well, it was lovely to meet you. I'm gonna go ahead and end session, but thanks everyone for coming. And thank you, Dr. Psych. And thank you, Alexi.
Thank you.
Bye.
Have a good one. Bye.